And in the ER, a lot of times moms miscalculate their contractions and they come pulling into the horseshoe out in triage and they pop out a baby. And I have never been that girl that has caught a baby. And it's on my nursing bucket list. But nobody that works around me wants to participate and have
Yeah,
that experience.
everyone else in the department's like, no,
No,
we
yes.
don't do
And
that
I
here.
have this whole romantic vision. It's going to be a boy. He's going to come out. He's going to be fat, juicy, 8 pounds. I'm going to hold him up and like Lion King him while everyone, the crowd that is gathered, cheers. And everyone assures me that's not how it goes, but
Like, no, it's not gonna be like that at all.
that's how it is in my mind. So,
That's funny.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing podcast. My guest today is an ER nurse, a flight nurse, a nurse educator, and the co-host of a popular nursing podcast called the Q Word Podcast. She is one of the people who inspired me to go ahead and start my own podcast and has been willing to mentor me as I get started. You are going to love this episode with my friend, my mentor, Nyssa Hattaway. Enjoy. So I have a little bit of a bone to pick with you because you have gotten me into a really time-consuming, really time-consuming habit here and hobby. So thanks a lot for that, pal. Now I spend all my days off podcasting, either recording or editing or planning and plotting. And I have you to thank to that for some degree. You inspired me to get started and just do it.
yep.
So I don't know whether to thank you or curse you. I'm not sure which is appropriate.
I know exactly what you mean. It's definitely addictive. It's not a cheap hobby.
No.
And now nursing is not only your career, but it is your entertainment too.
Right?
That's next level nerd level.
How twisted is that?
Yeah.
Yeah, I
It's
mean
next level.
it's bad enough that my coworkers always say, you're so involved in the ENA, so when you're off, you're still emergency nursing. And then now this, and they're just like, no. So, but it's been a lot of fun. It's been a blast.
Isn't it fun?
It's been a blast. I think I have about, I don't know, I think I have like 15 episodes out now. I have probably about another 10 recorded that are in various stages of completion. And it's been fun. I'm learning more each time I do it. I'm having a blast. And it's making a difference. I figured it'd be me and my wife and a couple friends that were listening to the podcast. And actually, we're getting pretty decent numbers for, the first couple months. I think we're at like 350 downloads I'm at like 350 episodes, or 350 downloads per episode, which isn't bad.
It's amazing.
That's about 325 more than I thought there would be. So.
Exactly. Lisa and I were pretty sure it was going to be our moms, and that's it.
Yeah, you're like your mom and spouse, and that's about it. Yeah. That was what my thought was too. And then sure enough, it seems to be working out okay. People are listening, and I'm hearing from people who listen, and I get the occasional. I think I told you I was at a conference in Roswell, New Mexico, and this woman came up and said, "Hey, I listen to your podcast. I love it." And I was like, "How cool is that?" That someone in Farmington, New Mexico, listens to my podcast, and
yeah, it makes all that technology frustration and hours of editing and scripting and so forth makes it all worthwhile.
Makes it all worth it. And you're sitting there going, "Okay, that's kind of cool." But I appreciate you taking the time to do this with me.
Yeah.
So start off by telling the audience who you are, what you do, and a little bit about yourself professionally.
Okay. My name is Nyssa Hattaway. I fly full-time for a Life Flight helicopter in Central Georgia. My background is all ER nursing. I came straight out of nursing school into a level 1 trauma center. I still work at that hospital today, PRN. I've done a lot of things over the years, but I've never left there, probably never will. I'll probably die right there in that ER. That would be fine.
They'd be like, "Can you clock out first, ma'am, please?"
That's right. I need a work excuse. And so I worked there, grew up there. My foundation for nursing was built there. and became the department-based educator and did all my overtime in the ICUs. So I worked medical ICU, surgical trauma ICU, neuro ICU, and burn ICU. I also did some agency work at the other 2 ERs in town. So I've worked at a large community hospital, a small community hospital, and then a critical access hospital,
Wow.
which is 6 beds. So everything from level 1 to critical access. I have done clinical instructing for a local nursing school, which I absolutely loved. And I am the co-host of an emergency nursing podcast. It's called the Q Word Podcast. And my nursing passions would be family presence at the bedside during resuscitation, precepting new grads, and professional development, specifically advanced certifications and clinical ladder type stuff.
What advanced certifications do you have?
I have CEN, CPEN, and CFRN.
Hoorah. Which one's next?
There's
always a next.
That's right. I actually have my eye on CCRN. That's probably what I would like next.
Okay. I was talking to, I know you've seen the name Pam Bartley, who does all the CEN and TCRN and all that, and all those reviews. And she was telling me that the CCRN was her first certification. And she said, out of all the ones she has, she thinks it's probably the easiest.
Oh.
And I was like, I've heard a lot of things, but I haven't heard that. And she's like, oh yeah, because it's so much easier. She's like, it's circulation, it's respiration, circulation, and neuro. She's like, they don't throw in all these oddball things that the CEN throw in. She's like, it's pretty pure. She's like, you need to know it at a deep level, but it's pretty pure.
Very interesting.
Which I was like, interesting, because that's one to me that scares me a little bit. And I don't have any ICU experience to draw from, so I wouldn't be the right guy to take the test. But that's one of those ones that I always heard was a pretty hard test.
Yeah, same.
So I did the TCRN, and the TCRN was it was different because it was more than just ER. They include ICU, they include the med surg, OR, the whole shebang. And they were asking questions like, your patient's 10 days post-op, and I'm like going, I don't know what to do with a 10-day post-op patient. It's not what I do. But you got to know it for the test. So,
right. Well, one of my mentors a long time ago, she was telling me that when she first took CEN, the only option for renewal was to retest. And she said that she used to love doing that because it would keep her fresh, keep her in the books, keep her digging, keep her up to date. So I decided at that moment, whenever I renew, I'm going to retest every single time. So I have 3, which means, and they're spaced out so that every year I have a test and then I have 1 year off.
wow.
But they're on a 4-year cycle. So if I had 4, that would make sense. I could fill that year. So I don't know.
Yeah.
Maybe.
I just retook the CEN exam, and I probably wouldn't have retaken it, but I let it lapse. So I was like, crap, now I got to go take the test again, which actually turned out great. I mean, I used to teach a CEN review, so it was just a matter of kind of dusting off some cobwebs and going and taking the test. But it was a good challenge for myself to go do it, and kind of reminded me that, okay, I still kind of know some of this stuff.
Yeah.
So.
And when I was the educator, I felt like it was really important because I could say, I just recently took it and this is what the experience was like.
Yeah.
But I remember sitting out in the parking lot going into my first retest and thinking, how extremely embarrassing will this be if I'm unsuccessful? This will be really embarrassing.
That was my thought when I was sitting there getting ready to go take the test. I'm like, what if I didn't pass?
Yes.
And I didn't tell anyone I was retaking the test. I just went and kind of quietly took it and just said, okay, it's done. But I kind of kept it kind of quiet because I was like, what if I didn't pass? If I had to take the test again, I'd be just devastated. I'd be like, oh my gosh, all those years I had the CEN and I just didn't even know the stuff.
Yeah, exactly.
So that's a little intimidating. So that's an intimidating thought right there. But I did the first time I renewed, they had a deal at the CEN where they said, okay, if you'll do the open book exam and track where you looked for the answers, whether it was something you already knew. If it wasn't something you already knew, then how long does it take you to find the answer, and where did you find the answer? And they said if you keep track of that material for each question, you could take the exam for free. So I was like, I'm in. Let's do this. That test was so hard.
Yeah, I've heard that. And they've eliminated it now. It's not even
Did
an
they?
option.
Did they? It's not an option anymore. It was a hard test. I was like, I mean, granule level, like the most detailed stuff. There's one I'll never forget. It was in, it was in the answer to the question was in the Jean Prail procedure book, and it was like the last paragraph of the sentence of the chapter, and I was like, seriously, that's where you're going to get your answer?
Yeah.
and it was just that granular, and I was just like, okay, I'm never doing that again. I'll go take the test all day long. So just to not have to do that, but I'll renew my TCRN this time by points, because I don't want to go take the test again.
Right.
But the CEN, I'll probably keep taking that test. So what made you decide to get into nursing?
So nursing is a second career for me. I have a liberal arts degree, and I had 3 little kids at home, and I dropped my daughter off to kindergarten and had my 2 boys in the car, and I pulled out at a stop sign, and we were hit on the side by a big logging truck.
Holy cow.
It was hit right on the side where my 7-month-old was sitting, and he was devastatingly injured. So we went by ambulance to the level 1 trauma center in my town, and he ended up spending 9 days in the PICU.
Wow.
And ended up coming back a year later for a craniotomy, and stayed in the same PICU for a couple more days. And going through that experience and watching those healthcare providers, the nurses and the physicians, care for him, and then also just seeing how his little body was able to heal itself with their help and direction, I said, this is something I want to be a part of.
Wow.
And so once we got through all of the 3 or 4 years worth of follow-up and the surgery and all those kinds of things, I sent my youngest one off to pre-K, and I went to nursing school.
Holy cow. So went to nursing school with 3 kids.
4. It was 4 by then.
4 by then. Holy
I added
smokes.
one.
Wow. That had to be intimidating.
Yeah, it was. Nursing school is hard. It's no joke, no matter what your life situation is. No joke.
I think that's absolutely true. It's I always tell people when they look at going to complete their BSN or MSN, I'm like, it's so much easier than the ADN. I did that. I was an ADN student, and my ADN program was just tough.
Yeah,
it was hard.
Same here.
So and I remember like you leave there feeling like you've been through boot camp, going, holy cow, we got through this and we survived, and now we get to go learn in the field. That's always kind of crazy. But
that's right.
So, at what point in your career were you sure you made the right choice?
When I went to nursing school, I was 100% sure that I was going to be a labor and delivery nurse.
Really?
I remember walking into OB clinicals, walking through the doors of L&D and saying, like, I'm home, like, here I am, finally. And was just sure that was what was in the cards for me. And so for my senior practicum, we were randomly assigned places to do our practicum. And I got neuro ICU night shift, and my buddy got ER day shift. And he said, man, I really need a night shift for my life and my work schedule. Day shift is going to make it really difficult for me. And I said something like, it doesn't matter where I go. Like, I'm L&D bound, so I'll swap with you. Do you want to swap? And there was that serendipitous moment where, a scheduling conflict ended me up in the ER on day shift. And when I got down there, and I mean, it had to be the first shift, maybe the second shift, I felt like, wait a minute now, what is happening down here? What is this secret that is being kept? I wanted to know everything, see everything, do everything. And I realized that the ER was going to be the closest place that that might happen. I've since realized that's an impossibility, but I still try. It doesn't keep me from trying.
Yeah.
And I remember the day that I made the decision, I was in the trauma bay, and we had this super combative patient, And my job was to try to like redirect him and calm him down and whatever. And I'm just this little nursing student. And
throw the nursing student in.
That'll
go well.
That's right. And this was back in the day where we had to wear white from head to toe.
Oh my gosh.
And he yanked out his 18 gauge, and I didn't notice it. And next thing I know, I look down and his blood is all over my white shoes. And I just remember thinking, I am going home tonight with someone else's blood on my shoes. How freaking cool is that? And there was something about that moment that romanced me, and that was it.
That's funny.
I was hooked.
The blood. Have you ever? There's a book that you need to read called The Blood of Strangers.
Oh.
And if I guess you haven't read it, it's a fabulous book. So
writing it down.
But it's one of those like, who would have thought that would be the thing that made you go, huh, this is kind of cool.
And in the ER, a lot of times moms miscalculate their contractions and they come pulling into the horseshoe out in triage and they pop out a baby. And I have never been that girl that has caught a baby. And it's on my nursing bucket list. But nobody that works around me wants to participate and have that experience.
Everyone else in the department's like, no. We don't do that.
And I have this whole romantic vision. It's going to be a boy. He's going to come out. He's going to be fat, juicy, 8 pounds. I'm going to hold him up and like Lion King him while everyone, the crowd that is gathered, cheers. And everyone assures me that's not how it goes. But
no, it's not going to be like that at all.
That's how it is in my mind. So
that's funny. I have a friend who's an ER nurse who, has said she wanted to be a labor and delivery nurse for I don't know how long. And she would always tell me, yeah, I'm going to do it. And then she never did. And then she was like, I just can't. She's like, I'm an ER nurse. What can I say?
That's right.
I'm like, I
sometimes
get it.
It picks you.
I get it. And sometimes as an ER nurse, you get to be a labor and delivery nurse too. Again, not willingly and certainly not to the chagrin of most of the department. Most of the department's like, oh, yeah, but there's always that one person who's like, yes. That's awesome. What's your favorite memory of being an ER nurse?
Oh, wow. So many favorite memories. What's my favorite memory? I have a lot of favorite memories when I was the educator, and nurses went and they successfully tested for CEN and they were just on cloud 9 and I got to celebrate with them. Or they completed their first night shift off orientation and nobody died, or lots of celebratory moments. I love being with new grads and students. I love sharing those milestones with them. I remember vividly my first IV, my first med air, all of those kinds of, my first patient death. And so it's easy to remember what those things look like through their eyes.
Yeah.
Those are some of my favorite. I have one of my favorite patient memories. So I told you the story about my son. I was driving the car. We were hit. He was terribly injured. So one morning, early in the morning, 7 a.m., I'm just coming on. I've got a few empty rooms. And I get this lady assigned to my room. And when I start talking to her, she had been in an accident the day before. She was driving. They were hit on the side where her teenage daughter was sitting, the passenger side. Her daughter was going into her senior year of high school, and she was an athlete, like headed to college on some athletic abilities. And the girl had broken her leg and ended up in the children's hospital and was what had been wheeled away that morning to go to surgery to repair her ankle.
Wow.
And the PICU nurses had noticed that this mom had a lot of bruising and injuries and convinced her, while your daughter's in the OR, why don't you go downstairs to the ER and be seen yourself? You put all that aside.
She hadn't been seen yet.
You're right. That's
wow.
Right. So she came down and ended up in my room, and she ended up having some bruising, nothing terrible by the way of injuries, but she was heartbroken. She had this terrible mother's guilt. And I felt like at that moment I could say to her, I literally know how you feel, and tell her the story about the reason why I am your nurse today is because almost an identical scenario. And I'm going to tell you the things that it took me years to understand, that this is misplaced guilt, that sometimes the accident is just an accident. You're not a bad mom. You're not a bad driver. And man, did we bond, and we cried and we hugged it out. And, but I just felt like of so many of the patients that you can be empathic about, like I really, really knew exactly how she was feeling in that moment.
Yeah.
That's one of my favorite moments.
Did you have that kind of guilt after your accident?
100%.
Yeah. That's too bad.
I wouldn't drive for a very long time. My kid was so little that I don't know if her teenager was going to say things to her, if, her senior year was ruined, or her, college. I'm sure those are all the things that she was thinking of.
Yeah.
But yeah, absolutely. Maybe even still a twinge of it today, like almost 20 years later. Yeah.
Wow. How cool is it that we seem to end up in just the right place for just the right patient? And
that's right.
I've never been able to explain that. Nobody ever can. But I don't know how many times I've felt that, like where I was like, okay, this is exactly who I need to be here for today.
That's right. And I felt it a lot of times. I think with that particular lady, it was so literal that it was probably the time that I felt it the most.
What a cool thing for you to be able to be there for her, and for her to hear your words that hopefully made a little bit of a difference for her.
Yeah.
So that's really cool. Tell me about a patient who changed the way you practice.
Okay, so it's a little bit silly, but when I was a new grad nurse, I had a patient. She was a college student at one of our local colleges. She was young. Her parents were far away. She came in and was diagnosed with appendicitis. So she was going to OR for her appendectomy. And I was night shift at this time. So she came to my room, 11 o'clock. She had a couple friends who stayed with her for a few hours, and then they sort of bailed. And so she was by herself, and she was going to OR at like 5 o'clock in the morning. And this was back in the time where everything was on paper. And so to send a patient to the OR, there's a stack of paperwork that has to be done. It has to be just right, consents and timeout forms and a copy of the chart and 3 pages of stickers and on and on and on. And I had been caught a number of times as a new grad with some T was not crossed, some I was not dotted, but I was determined that I was going to get it right this time. And so I spent a lot of time getting all of the paperwork in order, and I had this big fat stack of stuff when the transporter came to get her, and I was really proud of it. Man, I handed it over like it was a senior thesis, like, look at this, and here's your antibiotics on call to go on top, like a cherry on top. And super proud of the job I had done. And he rolls her out of the room, and she's got tears running down her face. And I looked at her, and in my mind, I imagined some high-powered surgeon standing in the OR, all scrubbed out with a scalpel in hand, ready for this girl to roll right in and go right to it. And I thought, I can't stop this process. He's here to get her. She's got to go. I don't want to delay anything. I'm just this new grad nurse.
Yeah.
And so I sent her off. And for the next 2 hours until my shift ended, it haunted me. I didn't find out from her, was it fear? Was it nerves? Was it pain? Was there something I could have done to help any of those things? And so I sent her away in tears and lonely and maybe in pain even. So I vowed that day at shift change at that nurse's station with like my fist up like Scarlett O'Hara on the steps of terror, like, God is my witness, I will never let a patient roll away in tears ever again.
Yeah.
And so now when I have a patient in tears, stop. Let's go back into the room. Let's talk about this.
Yeah.
But it gets worse than that. Like, it spills over where if I'm wandering around in the department running an errand and your patient rolls by with tears in their eyes, I'm going to stop everything right there, even though it's none of my business, and find out what's going on and how can I fix it. And if I'm in the halls of the hospital and I see somebody standing there by themselves in tears, I'm going to stop and I'm going to talk to them. And I find a lot of times when you say something, especially when it's a visitor, when you say, "Are you okay?" they say no. I mean, they say yes.
Yeah.
You say, "Are you okay?" They say yes. And, they're kind of shutting down the conversation. And so I always follow it up and I say, I don't believe you. Your tears are telling on you. Do you want to talk about it? Is there something I can do to help? And oftentimes they just need a human connection. They just need to be heard or to have someone tell them, "I'm so sorry." Generally, there's not a lot of action items that I can do to fix it, but I don't I don't shrink away from crying people anymore.
That's hard because I'm a sympathetic crier, man. If I'm sitting there and you're crying, I'm gonna be like, "Oh, you need to stop. Come on now. let's."
Yeah.
Yeah, I tend to use a little bit of humor, but I'm kind of the same way. Like if I see somebody who's there and they're struggling, I just can't help myself. I just can't help myself from just being like, "Hey, you doing okay? What's going on? Can I talk to you?"
Yeah. Let's talk. Yeah, and I tell new nurses it's okay to cry with your patients. Don't, if you're feeling an emotion, they need to see that now if you're going home every day from your shift and crying yourself to sleep, that's a different thing. But it's okay.
Let me introduce you to a therapist.
Yes, this may not be the gig for you. But yeah, I mean, we feel those human emotions too. So
yeah, I mean, if you don't, then you're in the wrong profession.
Yeah.
Truly, like if like things don't bother you to that point, then you're absolutely in the wrong profession. You shouldn't be working with people. You should be working with like plants or something.
And I don't cry at every single code anymore, but there will always be one that hits me out of left field where, I remember one where the kid had the same name as one of my kids and it just put me right there, or the kid's the same age as my child at home, or the circumstance is the same as the way my dad passed away, something like that will hit me and touch me a little more deeply than other ones.
Yeah.
So I think it's okay to cry with patients.
You told a story about that online a while back. Can you share that story?
We had a patient that was in the trauma bay, and the trauma resuscitation was unsuccessful, and the patient died. And they had just been going about their daily life, whatever it was they were doing that day. So of course they're in street clothes that have been cut off and now thrown all over the trauma bay, and there's boots, and there's a cell phone, and the cell phone is in the patient belonging bag, and it's just someone is war dialing this person. Someone is missing this person. So wherever they were supposed to be, they didn't make it to, and someone immediately recognized it, and they're just calling them over and over and over, and this ringtone is going off over and over and over. And I've had this experience a few times. One time I was on the scene at the helicopter, and the patient was being extricated, and someone handed me his cell phone, and I had it in my pocket, and somebody was war dialing him over and over and over again. It just reminds you that this person has been missed. They didn't get where they were supposed to go, and somebody has noticed it. And the ringtone is the same as my husband's ringtone, and I told him, like, you know what, you're going to need to change that.
Change that ringtone.
I'm going to need you to change that, sir.
I lost a family member, and I had a ringtone on my phone, and my phone rang all night that night. And at the end of the night, I was like, yeah, that ringtone's done. Yeah. I can't, like, I even still, and it's a movie ringtone that like everybody would think I would really be into. And yeah, not surprised if I had it on my ringtone. But I just, even every time I hear it, I'm just like, ugh, you just get that little twinge of, yeah, no, I don't want to hear that. It brings back some memories.
Yeah, and it takes you from, where you're deep in the resuscitation, trying to remember all those clinical things to do quickly and efficiently and evidence-based practice, and then it puts you right back into the humanity of it. This is a person that has a family, and somebody, that loves them is missing them right now.
Yeah, for sure.
And about to get some really, really bad news.
That's yeah, you're absolutely right. That's it's hard. It's just hard to deal with sometimes. You're just like, man, this is going to be a rough one. So you mentioned you cried with in front of a patient before. Can you tell me about that?
I think I've cried with a lot of patients before. The most recent one that I can think of was a lady whose husband was dying. He was dying of cancer, and then he had an acute event where he fell, and now he's dying acutely from an injury from the fall. And so she knew that he was dying, but that, in all likelihood, she'd have some days or weeks with him. And now it's right here, right now, probably going to happen in the next few hours.
Wow.
And I remember at transfer of care saying to her, I'm so sorry we had to meet in these circumstances. I hope the very best for you. And I was turning around to walk out the door, and it was like a movie scene where she said, you would have really liked him. And I was like, So I turn around, clearly she needs to talk and
Yeah.
she needs to talk about him.
Yeah.
And I said, I bet I would have. And then she started talking about him and what a great
Huh.
guy he was and how much she loved him and how long they'd been together. And uh, her little heart was breaking and it was breaking mine. And man,
One thing leads to another. So we had,
and we're crying.
and here we go. We had a patient not just a couple weeks ago. I guess it's about a week ago. Um, I was taking a report from the other house supervisor, and she goes, "Oh yeah, there's this lady in the ICU. Don't talk to her. She's gonna break your heart. This guy's dying up there, and his wife's just a mess, and she's having a really tough time." She's like, "Don't talk to her." She's like, and then this house supervisor is like tearing up as she's telling me, to avoid this woman at all costs. Right? So
Wow.
I started laughing. I said, "Okay." I go, "So what you're telling me is I need to go up and see this family?" And she's like,
First thing. Yeah.
"You need to go up and see this family." So she's like, "Bring tissues." So I was like, "Okay, that's fine." So threw some in my pocket and go up there to go see the family. And, the family, everything had changed for the family. The family was in the ER and they were under the impression that things were hopeful and he was going to be okay. And it was clear that that wasn't the case at all. And by the time I got up there, they were coding him again for the third or fourth time. And, they're like, the ER doctor made it sound like this was going to be okay and that we were going to get through this. And I was like going, shame on him for giving them that kind of hope. And who knows what he said in reality. And, they always take it a little differently than maybe they should. But sure enough, I go, here's what I know. I said, and I've been here for all of 5 minutes. I go, we are breathing for him because his lungs aren't breathing on their own. We're circulating his blood for him because his heart's not working. I said, I don't know anything about him. I don't know anything about his history, but I do know that he's fighting for his life. And for the family to hear that, they were just like it just sucked the oxygen out of the room. And, they're like, oh my gosh. And they're like, 87 years old, and they're like, he's full code. We got to do it all. We got to save him. And I'm like going, fight you want, then fight we will. And said, absolutely, that's what we'll do. So we did. We fought with him all night, and coded him a couple times that night. And just in talking to the family, and the wife was so sweet. And every time there was a code blue paged overhead, it was him. And I would come from wherever I was and go to the ICU, and I'd walk by and she'd be like, I hate seeing you. I'm like, I know you do. And she's like, this means things aren't going well. And I go, things aren't going well. But then we sat down and we were just kind of talking. She was telling me about her husband. She's like, you would have really liked him. He was a really nice guy. And I go, what did he, one of the questions I always ask, I said, what did he do when he was a working man? And she's like, oh, he was an IRS agent. I go, I'll be right back. We have to stop this nonsense right now. And it just kind of diffused the situation. The family just starts cracking up laughing. I'm like, we can't work this hard to save somebody who worked for the IRS. I go, it's just not right. And, they all started laughing, and it just kind of made things a little bit lighter. And when they finally let him go a couple days later, I went in and he had just died, and I went up there and see the family, and she gives me a big hug, and she's like, she goes, I got to tell you, you really would have liked this guy. And I was like, well, besides him being a tax guy, I probably would. And she started laughing. And I was just like, those little connections you make with these families that they'll never forget. And, more stories for us and memories for us. Another one of those patients we won't forget, but certainly they won't forget the interactions that they had with us, the healthcare workers.
Yeah, and they don't know anything about epi every 3 to 5 minutes, or a STEMI within 90 minutes, or
they don't care about any of that.
Blood cultures. No, they don't know anything about that. But what they remember is those kinds of conversations and moments.
Yeah, exactly. So, all right. Tell me about the first med error you made.
Oh man. it is burned into my brain. It was so bad. So I went ahead and got it over with on orientation before I even.
Oh, get it over with.
That's right.
Get the first one done.
And it was a big one. I had a patient, a little lady with some cardiac issues. So she was on a heparin drip, and she was in admission hold. And this was in the day where if your patient got admitted, that you might as well shut that room down for the rest of the day because you're going to be taking care of her.
Yep.
So my preceptor and I had been going back and forth with her heparin drip all day, turning it off because it was too high, and then turning it back on again. And she had normal saline running too at some kind of rate, 75 cc's an hour, whatever. And at one point I heard an alarm beeping in her room. The heparin drip was off at this time. And I went in there, and the saline was beeping occlusion or something. It was a channel error. That's what it was. It was channel error. And so I had been taught, even in just the few weeks that I had been there, that you can, this is one of the pumps that has the brain, and then you can put 2 modules on one side and 2 modules on the other, any combination of that.
Yeah.
So we had one on this side and one on this side, and showing me channel error. So one of the troubleshootings that I had learned was that you can pop it off, move it around to the other side, and if it was a dirty sensor or whatever, it'll start working. So that's what I did, and it did start working again. And so went about our day. Then my lady got admission orders, and she got a bed. And one of the admission orders was to give her a 250 cc normal saline bolus. And so my preceptor said, "Can you go and hang that bolus, and then we'll send her off to the floor?" And I said, "Yeah, absolutely." So she didn't come with me because we were doing normal saline, not heparin, high dose, high alert medication, right? Yeah. That you have to have 2 people to sign off. Well, she didn't come in because it was normal saline that I was going to bolus, right?
Yeah. Nothing high alert about that.
Right. So I set the pump for the 250 cc normal saline bolus. The transporter comes, takes her away to the med surg floor. And 5 minutes later, I get a call from a med surg nurse named Jennifer, who is screaming at me, "What have you done?" And I was like, "What are you talking about?" She said, "You bolused this heparin drip is dry. You bolused the whole thing in. What have you done?" I was like, "That's absolutely not possible. I don't know what you're talking about." And she's like, "Well, I'm standing here with this patient. This bag is dry, and whatever." And I was like, "I mean, that's 100% not possible." And so, we just couldn't figure out what had happened. But they had to do, they drew an emergency PT-PTT. Sure enough, it was sky high. They had to give her the reversal agent, the whole deal. And I just was beside myself. Like I couldn't figure out what was happening. I felt sick. And it was right at the end of shift. So I went home, and I laid in bed all night long, tossing and turning, not one wink of sleep. Yeah. And as I laid in bed, I went through every single minute of the day with that lady till I got to the minute where I popped that channel off and moved it to the other side. And that's when it dawned on me that all day heparin had been channel A and normal saline had been channel B. But when you pop it off and move it to the other side, the computer reconfigures it. And now it's the opposite. And so when I had hit channel B, which had been normal saline all day, it was heparin.
Like muscle memory comes back to haunt you. It's like the muscle memory comes back to haunt you.
That's right. That's right. And so there I am in my bed at 3 o'clock in the morning, and I realized it was me. I did this to this lady. It's my fault. I figured it out. And so the next morning I called at 7 o'clock. I wasn't scheduled to work. I called the charge nurse. It was the same charge nurse who had been on the day before and knew this weird situation had happened. No one could figure out what was going on. I called him and I said, "John, I figured out what happened. It was me. Just let me know where I need to hand my badge in, and I'll be on my way." He said, No, you're not quitting. Let's figure this out. So we wrote up the incident report. I think we did an addendum because we'd written one up the day before, but we just didn't know what to put in it. We couldn't figure out what had happened, what had gone wrong. So now we know. Luckily, the facility has a robust, just culture. And so, one of the first steps when something is done inadvertently like that, before you even re-educate, is to console the person who's made the mistake.
Yeah.
And so I was able to find out how the lady had done overnight. She had done well. She'd had a nosebleed, but that was the extent of and it was probably from her, deranged clotting.
Yeah.
And but that was the worst of it. And they'd gotten her back therapeutic again, and she was okay. But, if she had fallen out of the bed and bumped her head,
Dunzo.
yeah. So it was a really big deal. It was horrifying to me. And all these years later, whenever I give heparin, it doesn't matter if it's a drip, it doesn't matter if it's a sub-Q, whatever. I still get like butterflies in my stomach, double check, triple check, quadruple check, because of that situation. So yeah.
I bet. Holy cow.
Yeah, it was a doozy.
That is a doozy. It would be and it's kind of funny that you replay it and you're like, oh, and I just can't even imagine like the pit in your stomach right then when you're like, oh, that's what happened.
That's me. I did it.
That's how, yep. I understand. I've been there. That's for sure. Where you're like, oh, yeah, that was probably me. Yeah, I probably did that. And you're like, oh, that's a tough one.
I've made med errors since then, but I'm 100% sure that that's the biggest one I've ever made.
Yeah. That's a good size one for sure. So, tell me about a patient that touched your heart.
Let me think. A patient that touched my heart. Well, we talked about the lady with the little girl, the car wreck. That was one for sure. I had a patient that I had to rewind myself on pretty significantly. When I was in nursing school, I worked in the newborn nursery neonatal ICU, and as a tech, and we had a baby that was in there who was born to a mom. She was a crack addict and she was a prostitute, and she had HIV, and we were waiting to see if the baby had HIV as well. Tests had been sent out, and we were going to find out whether this baby had contracted HIV from her mom. And I remember being super judgmental, like on the surface, this mom, just this poor baby has no, not a lot going for her. And this mom is just, got a lot of strikes against her too. So I remember being pretty judgmental. And then as I actually met the mom and found out her backstory, her story was even more horrific. She had been raped at age 12, and that's when she had contracted HIV. And
Wow.
So when you're a 12-year-old with HIV and a post-rape victim, no wonder you turn to things that are not not great. So yeah, that was one that made me realize that, maybe I should suspend my judgment when I don't know the whole story.
It's always a whole lot more to the patients than we know.
Yeah.
It's always I'm always kind of surprised. I don't know why it surprises me anymore, but you come to a kind of a snap judgment, and then you find out more about them, and you're like, huh, look at that. What's the best advice your mom gave you that turned out to be pertinent to your nursing career?
My mom. Wow. Let me think. My mom was in the medical industry. She was a medical assistant for a long time in a pediatric office. And so she actually gave me practical advice about distraction therapy and pain, bubbles and Band-Aids, drawing pictures on Band-Aids, and putting Band-Aids all over kids, not just where they have the boo-boo, because they're obsessed with Band-Aids. She's really, really good with little kids, and taught me that, how to be creative and distracting. And distraction therapy is some of my favorite therapy. It works on adults too.
I was going to say, it's not just kids.
Yes, that's right.
I was talking to a nurse recently who was saying she was getting ready to start an IV on a patient, and she handed the patient her phone and put it on Tinder, and she's like, yeah, go ahead and take a look, see who you think would be a good fit for me.
Swipe right for me.
That's right. And she's got the patient sitting there looking through her Tinder profile and like going, oh God. Of course, this came up when we were, and she'll know who this is when she hears this, and it'll be our little secret. There was a table full of us at an ENA conference, and everybody was kind of group, Tindering for her, which, is kind of going around there. What do you think? What do you think? What do you think? And we're like, no, yes. And I was just
dating
like,
by committee. That's fun.
right?
Seems fun.
Yeah, that'll go really well. That'll go really well.
And if it works out, we all get to take credit for it.
That's right. If it works out, we're all going to take credit. So
I always tell kids right before I'm sticking them, I always say, you can scream and you can shout and you can cuss as loud as you want. You just can't move.
Yeah.
And kids look at me like I'm allowed to be loud, because usually everyone's telling me to be quiet. I'm like, no, you can yell as loud as you want.
Yeah, go for it.
And sometimes I egg them on and say, that's loud. That's as loud as you got. Come on, you can be louder.
That's funny.
Just be still.
I do the same thing with adults when I'm going in to start an IV. Usually by the time I go in there, they've already been stuck 4 or 5 times, and they're just done. And they call me, and I'm like, if you would have called me 4 or 5 times ago, I could have maybe got one of these easy ones, but now I got to really look. And I always kind of joke around. I'll be like, yeah, no, I've never done this before, but it looks really easy. And they're like, what? And then they realize I'm kidding, or I'll be like, yeah, I got a brand new glass eye and things are going really well.
Oh my gosh.
And then the whole time they're like this going, do you really have a glass eye? Which one's a glass eye? And I'm like, I think it's both. and most patients appreciate it, but there's the occasion that are like, just start the IV, dude. Yeah. I'm not here for your comedy show. Yeah. I'm like, oh. That's too bad for you, because I'm pretty funny. So.
Yeah. Well, that's what I'll tell the kids. You can scream, you can cuss, and their moms will be like, no, you cannot.
Hey, hold on now.
Well, you have to follow mom's rules, I guess.
The nurse can tell you that, but I'm still going to whoop your ass.
Mm-hmm.
So what's the best advice a mentor ever gave you?
Oh, so this is advice I pass along often. My mentor, Janet Findley in the CVICU, says that task-oriented nursing kills patients.
What do you mean?
So when a nurse is so busy saying, I need to get a full set of vital signs, I need to get a line, I need to get the labs, I need to get their med list, and they're not assessing their patient, they're checking boxes, things get missed and patients die. And if you're so busy worried about getting the aspirin in and making sure that if they're left or right-handed, or if they'd like a visit from the chaplain, and you don't notice the change in their respiratory status or the rash that's now developed or whatever, that's when patients die.
It's a good point.
So you have to pass that advice along cautiously, because new nurses have to be task-oriented. It's a coping mechanism. They don't know yet how to do it otherwise. Yeah. Experienced nurses are doing tasks as they assess simultaneously. Yep. So you're checking boxes, but meanwhile you are watching your patient like a hawk as you start the line, as you put the leads on. You're looking at their, do they have a rash? Are they breathing well? What's going on? And you're doing it at the same time. But if you get too deep into checking a box, patients suffer.
Absolutely. Yeah, I think. It's like, don't get so task focused that you don't see the forest because there's too many trees.
Right. So,
and it's easy to do. I can see where people do that pretty easily. So, right. Especially like you said, as a new grad nurse. So. Yeah.
Well, and it's my example of my crying patient. I was so busy worried about the paperwork that I missed this whole piece with the patient. She didn't die, of course, but I could have done much better nursing care if I had paid attention to my patient versus checking boxes.
It makes it tough. So interesting. How do we convince new grad nurses to be less task oriented and more care oriented, or more big picture? How do you teach that? Can you teach it, or does it just come with time?
Yeah, I think you can teach it, and I think it does come with time. Sometimes as experienced nurses, the things that we're doing just from our gut instinct, we're not narrating out loud. We're not passing that along. So it looks like we are just doing tasks. But when in actuality, you're looking at every, bit and piece and getting a feel for your patient and paying attention to those vital signs and what does that EKG strip look like? Those are the kind of things that we have to verbalize out loud, so that our preceptee, our student, can watch see our thought process, hear our thought processes, as we're going through what looks like a task-oriented assessment. So I think and I think over time, nurses get better and better at it as they move from novice to competent to, on to expert. You learn, what's normal, what looks worrisome.
It's like it reminds me of when you're teaching TNCC and you're like, okay, tell me what you're thinking. Tell me what you're thinking as you're doing it.
Loud.
Say everything out loud.
Talk it out
as you're doing it, instead of you're going, okay, I'm looking at the patient. What do I see? What do I, and you're like asking all these other questions, like, okay, while I'm doing this, I'm also thinking this. You're kind of talking your way through it, because that's what we do.
And the tricky thing about that is, just like with TNCC, where it feels so artificial and so forced, it's not a natural way that we do things.
Yeah.
But a good preceptor, a good teacher will recognize how to add that in, because it's not the way we take care of patients. We're thinking all these things in our head. We're not saying them out loud.
Yeah.
But when you have a student that you're teaching, you have to click into that kind of TNCC artificial mentality.
Yeah.
You're exactly right. That's exactly how the mega code goes.
Yep, exactly. I remember the mega code from ACLS. Holy cow, that is like the scariest thing ever for a fairly new nurse, where you're like going, oh no. You're like, no matter what you do, the rhythm's going to change.
That's right. That's right.
You're like, great, here we go. Tell me about a patient who made you laugh that you'll never forget.
Oh man. All right. I think I can think of two off the top of my head. So I was charging, and we had a little old man in one of our critical rooms who had come in fluid overload. And those are great payday, because you can do a few quick interventions and turn them around oftentimes and get them, where they were half dead. Now they're going to the floor for a day or two and then home. And that was his case. That's what we were going to do for him. His nurse was super busy. He'd gotten a room to go to the floor. And so I went in as the charge nurse to fill him in and said, we're going to send you to the floor. We've got respiratory on the floor as aware, what we're going to do to keep your breathing in control, and you're going to do great. And he looked at me. Grandpa had game. He looked at me and he was like, "Are you my breathing treatment? Because you just took my breath away." What? Are you kidding
awesome.
me, sir?
You're like, that's great.
You just made this super middle-aged, frumpy nurse's day. Are you kidding me, buddy? Precious.
That's
you
hilarious.
just made me blush, sir, and you can't do that very easily to an ER nurse. It just caught me so out of left field. The other one that I remember that made me laugh, so, we kind of talk about nurses have a special kind of humor, and it's not for public consumption. So this one falls under that category. So I had this lady. She was acute psychiatric emergency, and she was off her meds, and she was in a manic cycle. And we had her out in a hall bed, and our acute psychiatric stabilization rooms were full. So she's out in a hall bed, and she's been chemically restrained, and she is sleeping like a little angel. And and she has been for several hours. She's been calm and quiet and asleep. And I'm at the nurse's station. It's probably 2 in the morning, and I'm charting, doing some, paperwork, something or other. And out of nowhere, she sits up bolt right out of her sleep at 2 o'clock in the morning in a nice still ER and starts singing Maroon 5's "I'm not crazy, I'm just a little unwell, I know right now." And we all looked at each
Lost
other.
it.
Is this real life? Is this happening?
Are we being punked?
Do we join her? Do we laugh at her? Do we sedate here? Like, what is happening? We are getting a free concert. It just was so unexpected and so ironic, the song that she chose. I just wanted to sing along and be like, "Me too, girl. Me too. Me too."
What does it take to be a stellar ER nurse?
Oh, wow. What does it take to be a stellar ER nurse? You have to be the whole package. So one of the things that you will hear sometimes in nursing is you will hear somebody say, man, she's a really good ER nurse. She's kind of crusty and she's a little bit jaded. She doesn't have a great bedside manner, but she's a really good nurse. And I reject that. I think
that butt nurse, yeah.
Anne Marie Papa calls it the butt nurse. That's exactly right. Don't be the butt nurse.
That's hilarious. Oh my God. Oh, that you would quote Anne Marie Papa of all people.
Yep, that's right. She calls it the butt nurse. So, I like to collect nuggets of wisdom for new nurses. I also like to collect lies that nurses tell each other. This is one of the lies, that you can be considered a good nurse, but not be the whole package. And it was a chief nursing officer that kind of showed me the light on that. And she's like, no, they're not a good nurse. Actually, they, you have to be the whole package. You have to have the compassion and the empathy. You have to have the clinical skills and the knowledge. You've got to be fairly efficient. You got to be able to recognize sick. And I think that as we go through our nursing career, we fine tune each one of those,
Absolutely. It takes time. And I don't know how many times, and you've probably heard this before, you hear so many people make excuses for that the butt nurse that, you're like, I know she's kind of a pain in the ass, but she's good. And you're like, I don't care. Doesn't matter. We had, when I was my first director role, we had a nurse who was clinically strong, and she was, nobody was quite as impressed with her clinically as she was, but she was a clinically strong nurse. And I remember her telling me, she was in triage one day, and she was telling me, I'm a triage expert. I teach people here how to triage. And I'm like, awesome. Let's talk. I'm going to watch you triage and let's see what you do. And, there's a few things that I'll tell you I'm an expert at, but I'm like, okay, I kind of get triage. Like, I've done enough of it that I feel pretty comfortable with it. So I watch her triage, and I'm sitting there and think to myself, holy cow, you are just terrible at this. Like, I don't know who told you were good at this, because you're not. And she I think equated good with fast, and I'm like, that's not. And then to watch her notes and over the length of time that I've seen her triage notes, and I was just like, you are not giving me any information in your triage note. You're essentially giving me their chief complaint and nothing else. I'm like, but it was one of those that they always made excuses for, and they were always, oh, she's good. She's just a little, but she's just a little cranky. And you're like, no, can't be that. You can't be the clinically strong nurse that just happens to be a bully. That's not going to work out. That's not going to work out for us. And
on the flip side, you can be the nanciest nurse that there is, just as sweet and loving and kind. But if you can't keep up with the pace and the acuity of an ER, maybe you would do better and be more successful somewhere else.
Yeah.
So it's all the way around.
Yeah, you're right. You're absolutely right. It's one of the nurses, I can't remember who it was. It says, we're gonna give them their opportunity to find their place to shine. Like,
somewhere else.
Somewhere else.
Somewhere outside of our department.
Not here. So it's just kind of funny. You're like, yeah, you got to be the whole package. I totally agree with that. Last question I always ask: 3 things. What are 3 things an ER nurse should remember, and what are 3 things they can just go ahead and forget?
So I would say my 3 things that an ER nurse needs to remember is, number 1, bring the family to the bedside during a code. Number 2, bring the family to a bedside during a code. And number 3, bring the family in. It's that important. So I'm a huge proponent. It's a passion of mine. I believed in the policy. I researched it. I wrote the policy for our hospital, and then I went through a personal experience with my best friend where she unexpectedly passed away.
Oh my gosh.
And it was not at my facility. It was another facility. And I was standing there. In fact, I called the code, basically yelled outside the ICU room door and said, it's happening right now. And they tried to kick me out of the bedside. And I politely would not go. And through that experience, it moved from being something that I thought was a really good idea for patients and their families. And it has become my passion and my banner to unfurl. So I would definitely say pursue that. And if you need help, I'm happy to help you with the research, the evidence, a policy that you can use in your facility, how to do it the right way. So just remember that family deserves to be at the bedside.
Do you remember the first time you had a family at the bedside? Because I remember my first time, and it was super uncomfortable. And if you would have asked me 20 years ago, I would have said that family presence at the bedside is a terrible idea.
Yeah. And, there is a right way to do it and a wrong way to do it for sure. And that's why having a written policy is so key, so that you can have a consistent practice that you can offer to every family. Not every family will choose it. Some of them know that that's not something they'd like to do. They'd rather stay in the quiet room. But overwhelmingly, the experiences that we have had are very positive experiences.
Yeah. I guess I'm sometimes surprised when I still hear there's objections to it.
Yeah.
It to me, it seems so, well, duh. I mean, of course we're going to do that. That's but right. I guess there's still people that don't prefer it, and they feel awkward being watched, because it is awkward being watched. It's awkward to have the family member there, but by golly, I think they tend to stop sooner when they see, here's everything we're doing. And they have the right to see us as medical professionals fighting for their life of their loved one the way that they want us to do.
That's right.
So I'm a big fan.
Yeah. I agree that it's really beneficial to the family. It's also beneficial to the caregivers, to be honest.
Yeah.
To be a part of those last few minutes. I do have a number 2 and a number 3 for real, though.
All right, let's hear it.
So my assistant manager, Sherry, taught me a long, long time ago that probably during that heparin incident, to be honest, the only people who are not making mistakes are the ones who aren't doing any work. And I have passed that information on. Please remember that. We're human. We're fallible. And mistakes will be made. Just don't do it on the big things. Don't cut corners. But mistakes are going to be made. If you're working, you're making a mistake.
Yeah, it does happen.
Yeah. The last one I would say for nurses to remember is when you have run out of ideas with your patient, when you're doing everything you can think of for your patient to try to solve their, whatever it is, their pain, their respiratory issue, their, whatever it is, and you are out of ideas, go and get a fresh set of eyes. I will see nurses being very frustrated and say, well, do you just want a fresh pair of eyes? And you'll come in, and if you're kind of removed from the situation, you'll pick up on, well, let's try this, or did you think about doing that? And it seems really obvious because you're removed from it. So I'm a huge proponent of grabbing a fresh set of eyes.
Absolutely.
Get stuck.
Absolutely. Sometimes, they're going to see something you've completely missed.
Right. So. You're so deep in it that you can't see it.
Yeah. Yeah, for sure. So, and what are the 3 things to forget?
The 3 things to forget the phrase, I'm just a nurse. Throw it out of your vocabulary. Nurses are the only member of the healthcare team that's at the bedside 24 hours a day. Absolutely. The only member. And nurses can make a difference. I am lucky enough to have my ER foundation at a magnet hospital. So when I have some crazy harebrained idea or I read something that I think might be beneficial at my house, I have a formal place where I can take it and say, hey guys, let's do this here. What do you think about, adding this to our toolkit? Nurses can be change agents. Nurses can be trailblazers. So forget about being just a nurse. I would say forget about pseudo seizures. I hate the idea that we are trying to catch our patients in a lie. If our patient is there and they are doing this thing and you suspect that it's not truly neuro, they're still there for a reason. Something is still going terribly wrong in their life. Maybe it's not happening in their brain. And this is kind of a newer concept that I have gotten on board with too, that Dr. Jeffrey Jarvis says, trust your patient. It's so much easier when you do it that way. Forget all this thing about dropping their arm onto their face and squirting water in their eye and whatever. If you suspect that it's not neuro, first of all, you can't be 100% sure unless you have an EEG on them right now.
Yep.
And there are seizures that don't look like traditional, compulsive grand mal. But if you suspect that it's not neuro, it's something else, then there are things you can say to them, like, I'm here, I'm going to keep you safe. I'm going to make sure that, everything's okay. And we're going to take really good care of you. And so if it's a psychiatric issue or some kind of attention-seeking behavior, they're your patient. They're in front of you. They're in distress of some kind. It's super frustrating when you've got half dead people all around you. I get it. It's super frustrating when you've got 20 people in triage waiting to be seen.
Yeah.
But it just makes your life so much easier when you trust your patient. And the last one's a little controversial too. Forget about if it's not documented, it's not done. Forget about it. And hear me out. Don't kick me out of the club yet. So it's obvious that documentation is so important, super, super important. But if you look at this idea that we talk about all the time, this axiom that we say, if it's not documented, it's not done. On a literal level, that's just not true. If I put a Foley in Mr. Jones in bed 17, I don't document it. Foley's still there. But that's not what we mean when we say that. We mean from a legal level, legal aspect. If it's not documented, it's not done.
Yep.
But nobody ever gives that footnote. We just assume that everybody gets it.
Yeah.
And so what happens is we focus on our charting, we focus on defensive nursing, and that becomes one of those tasks, and our patients suffer. And so about 15 years ago, a little more than 15 years ago, some research was done, and they discovered this phenomenon that we now call failure to rescue. And what it shows is that for anywhere from 4 to 10 hours before a patient codes in the hospital, they were giving us hints. Their vital signs were changing, their level of consciousness was changing, maybe their lab values were changing. There was something there that was tipping us off that this was a patient that was declining. Mm-hmm. And the reason that we know all that is because it's beautifully documented in the chart.
So wonderfully documented. You're like, all the evidence we need is right here.
That's right.
That says, hey, look at everything that happened and you didn't do anything.
Right. So you were so focused on if it's not documented, it's not done, that you didn't pay attention to what the documentation was showing you.
Yeah.
So it goes back to that thing about the whole package. Yes, documentation is vitally important. Of course it is. But so is assessing and reassessing and rounding on your patients. And so now my objection to this axiom that we pass on is the level of importance that it's given. Yeah. It seems to be number one importance that we're teaching student nurses and new grads, and they spend their time at the nurses station in front of the computer
all day.
Yeah. And so I would say, it is important, but make sure that you're balancing it with your rounding, your reassessing. Be very, very skeptical of your patients in the ER because they can go bad. Watch what it is that you're documenting. Watch those trends. That's why we do it so frequently, hourly or more.
Interesting. I remember once with the director that I worked with, and he said, let's do a little experiment. He was the executive director, and he said, let's do a little experiment. And he came down with the director and me, and we walked through the entire department. He goes, let's see where your nurses are. So he's like, how many nurses do you have on shift? And we had 15 or 16 nurses on shift. So we walked the entire unit, and he goes, let's see how many nurses we can put our eyes on right now. So sure enough, go by one nurse's station. There's 4 nurses. The 4 nurses assigned to that station, all 4 in a row, look like monkey see, monkey do, monkey, see no evil, hear no evil, do no evil. Walk through all 4 out of 4 right there. Go to the next nurse's station, 3 out of the 4 sitting in front of the computers, documenting, checking boxes, getting up and doing stuff, but home base being behind the keyboard. And then, in another room, we had 2 nurses who were sitting, doing some paper charting. And he said, we've seen almost every nurse in this department. And, there's one we didn't see. And we just assumed she was in a room somewhere. She could have been off the floor for all we know. But he's like, if they're there, where are they not? And he's like, they're not in front of the patient. He's like, they're not looking after the patient. He goes, we put computers in every single room. Every single room had a computer, a working, functional computer. So you could document right there. And not a soul was using them. They weren't logged on ever. They were documenting at the nurse's station, which meant they spent most of their shift at the nurse's station. And I remember at times we were reviewing security camera footage, and you watch the nurse's station for 12 hours and you're like, wow, Mary doesn't move much. You're like, good to know. And you're like,
make no mistake, this gig is not easy. Nursing is not easy. ER nursing is one of the hardest. You're doing it with minimal resources. You're giving up bathroom breaks and
all day. Yeah, for sure.
Meals and holidays and patients just get sicker and sicker, and they just keep coming. And you said it in one of your episodes, and this hit me like a ton of bricks. The ER is one of the only departments in the hospital, if not the only department, that can't say no. We don't say no.
Yeah.
And so I get it. I totally get it that it's just it just never ends.
Yep. It's true. It's a constant. It's constant. It's, we were talking the other day about how it's kind of a short shelf life for ER nurses because it's a hard job. It's a really hard job.
Yeah.
So that's all my questions. I can't thank you enough for spending time and talking to me and going through these questions.
Thank you for having me.
I'm a little disappointed there were no tears, but there's always next time.
I got a little choked up a few times.
Got a little choked up.
I've dialed them back.
I really appreciate you a lot, and I definitely want to thank you for getting me started on this podcast journey, and I blame you because you said just try it. Just record a few episodes and see how it goes. See if you decide you want to do this. And I did, and it was the beginning of the end of all my free time. So
you're welcome. You're welcome for the new addiction. I
appreciate that, and I appreciate you, and I appreciate you for taking the time to answer my questions and helping me out when needed, and I appreciate you and admire you. So
thanks. Same here.
So
you're doing a great job with this platform.
It's been a lot of fun. So I'm enjoying it, but it'll be. Ask me again in, a year when I've been doing it a year and see if I still enjoy it. Maybe a little bit different answer.
My prediction, you will.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.